I know that the first person I saw that we assessed as far as who had requested assistance in dying, I felt very comfortable talking to that person because what they were talking about was very similar to approaching one's death, implications for themselves, how the family are going to react to this, what are some of the things that are going on in relationships within the families that are almost intensified because of what's going on in the whole situation. Those are all very similar to working in palliative care over the years. Well, certainly it's a multifaceted role from our perspective, and I think we're involved in both the assessment. It's kind of like twofold as far as direct service part of it with patients and families. It's really trying to or not trying to, but participating in the assessment, and also supporting the patient and family through this process. So it's kind of, so how do we what the whole team is trying to do is to sort of ascertain whether someone meets criteria for this to be eligible for the assistance in dying, but we really want to also tease out what are some of the reasons why people are requesting it, and really understanding, what are some of the emotional things, or what is meant by some of the things that people say when they talk to us and answer our questions. So a lot of it is based on forming relationships with people, and I think what we bring to the team is probably not that we have a sole ownership on this particular factor, but I think we do know something about forming relationships and establishing relationships with people. So that's a big part of our role, I would say. Yeah.
I think that's right, and some of it is about process as well, so that social workers might bring knowledge about human behavior and emotions and psychology, but the process of an interview too is something that we'll focus on. So are we, something as simple as, are we sitting with an easy eye contact of someone who's uncomfortable in bed? And so those are the kinds of things that we will pay attention to. And family members, how are they coping with the conversation? Because the conversation sometimes may be the first time that it's been this thorough about the person's feelings about their life and their suffering and the meaning for them of having an assisted death. So that will be important listening, and our task is to help that process be therapeutic for everyone. If you have a patient in front of you that doesn't seem to know about MAiD, but seems to be talking about their suffering and saying, and they wouldn't say it to a social worker, or they might say, I wish the doctor would give me a pill. I wish this could be over. How long do you think this is going to go on? When do you think I'm going to die? And actually, sometimes people will ask social workers that because they know our answer isn't as important as the doctor's answer. So to me, those are all invitations to talk about what their experience is and what their suffering is, and explore that. And it's really emphasizing that the patient who is eligible for MAiD is in charge. They're in control of whether or not they access or exercise that eligibility. I think one of the ways that social workers can help support informed choice is to talk with patients and help the patient find the words to talk about what their experience is. So often it's the first time a patient will have thought about a complex subject. They'll have many, many feelings about it because it is complex. And so some of us can benefit from having someone listen to us while we find our way to describe it and have help with finding that language. I think a good counselor too can provide an opportunity for a patient to find words then to talk to the people that are really important to them about a difficult and challenging subject. So that's one way that a social worker can help a patient be informed, is by helping them to find the right questions to ask and the right ways to describe their own experience. So one of the parts of our role is to make sure that people are referred or get help that they might need in the areas that we would know about. So that might be counseling, that might be community services or resources, some guidance about how to plan the assisted death and how to have rituals or who might be involved.
I think as far as supporting families outside of grief, in terms of when we're involved in the assessment part, and we can recognize that families are having difficulty in terms of coping with what's happening, we would be reaching out to them too. Sometimes it's a matter of almost a way of including them in the conversation, because sometimes people, you get a sense that they maybe have something to say but they don't know how to say it, or they're afraid that they shouldn't be saying it, and so we'll be reaching out to them and you know, giving them, almost sort of facilitating them to be involved in the conversation as a family, but also reaching out to them individually. Sometimes when you're together in private, away from the conversation that you're having, we might just sort of have one-on-one conversations, sometimes in a hallway, in another room of the house, whatever. Really just sort of encouraging people to sort of, you know, if they have some thoughts or feelings or questions about what's happening, to just call us, and we can either arrange a time to see them privately, or we can just talk to them over the phone too about what might be happening for them, to sort of just recognizing that kind of support may be useful. When you're talking with families,
Yeah.
what you're seeing in the moment is very much a snapshot of what's happened in the life of this family. And families arrive at places, and often within healthcare settings, I think another role that we play is really just reminding all the team, and again, most people on the team know this too, but there's been a history, and sometimes there's also anticipated futures about, you know, what this family is going to be all about. So there might be stuff going on there that you can see, you can almost sort of see that's worth investigating in terms of, you know, what does this mean to that person, or have they had an experience like this before, or I don't understand where you're coming from when you say that. What kind of you know, what's, I get a sense that there's something that's happened here, and I know, you know, it's up to you if you want to go into this a little further, but, you know, what's happening for you right now, especially when we come to a point of really trying to determine, you know, just around things like, is this person making up their own mind independently, or are there things that are influencing their decisions, and especially when you pick up on those cues within the family, that's something that we would be, you know, quite ready to try and go down that road. And then I guess it's a matter of thinking about other teams who we interact with. Say we go into a facility where we're assisting someone in another healthcare facility, recognizing again, this is quite impactful on that whole team, and really having time to talk about with members of that team before someone dies about what is going to happen, and really talk to them about maybe what some of their concerns are, and then also afterwards to have an opportunity just to debrief and really to sit and say, well, let's talk about, you know, how this was for you, or how this was, and really giving them a forum for doing that kind of thing. And sometimes people are going to choose this regardless of the support they have. So it doesn't mean it's a failure on your part if a person chooses medical assistance in dying. That can't be underlined enough. It's crystal clear to us in all the situations that we've been involved with that people really know exactly what they want to do. And that's not going to, you know, the people that have gone through with this, that has not faltered. They've been very determined, they know, and they've had a lot of support. They've been very caring people around them, supportive families, supportive caregivers, and it hasn't really changed the outcome of where they're going. So a lot of it is, as Megan said earlier, listening for words and watching, you know, different interactions and reactions, and but also it's about, you know, just kind of going down that road with people in a respectful way.
And it's a feeling that this is different, it's a change, it's new, it's controversial. That's stuff that's going on in us as we learn practice. But in reality, there's nothing different about these conversations. They're conversations about suffering and about end of life that many healthcare providers have been having for a long time. I think it comes down to, even though it's new, we have to be confident that we know how to listen therapeutically.